Welcome, everybody. We're starting the final webinar of the year. I'm really excited about this. And we're going to have a Christmas themed after party at the end. Before we get started, I'm going to introduce my fellow host, Miller. Miller, we're tag teaming this event. Miller, I call him the use cases ninja. And we're going to be interacting with the panelists. We're bringing them on one at a time. And if you're an early stage founder or you're innovating, Miller is going to be available to give you some advice during the after party. How you doing,
Definitely.
Miller? How do you feel about the event?
Doing great. A little sad the last event of the year, but we have a fresh start from next year onwards. So looking forward to it. And we have amazing panels today.
All right, we're going to bring on the first one. And ready or not, Chris, here you come.
Hello.
Hello. Thank you for coming, Chris. And I wonder if you could set the table for us.
Well, first of all, oh, go ahead. Sorry, go ahead.
Actually, I don't know how to introduce you now because you wear so many hats. And
I've consolidated hats.
You've. I have the. I wonder. Can you describe your current hat?
Yeah. Outside of the Christmas hat, I have founded a company in April called Modular Feedback. Our slogan is reclaim the algorithm. And it's representative of the very reason why we're gathered here to talk about improving minority access, is because there is if you've read books or seen things like Karen Howe's Empire of AI or the book Careless People that was about Mark Zuckerberg and Meta, you see that there's this narrative where these people are dominating these algorithmic approaches for outreach and social connectivity, and by the careless ways they're going about it, there's a major failure in serving people on so many levels. I've spent my career 17 years in the healthcare analytics and AI space, entering the AI space proper in 2018. And since then, there's just a higher standard that we're focused on in healthcare. And it's the difference between, well, if someone gets it wrong at YouTube, then that means a bunch of people are going to be watching a bunch of content that doesn't fit the bill, or at Netflix they're going to disengage early. Well, in healthcare, you're potentially blocking off meaningful access to communications, access to high risk programs, things that have a really direct, not saying that YouTube and the information we receive doesn't have an impact on our lives, but it's much more tangible, much more serious when it comes to how we're driving lines between the care that we're receiving. So the basic concept. Oh, go ahead, Jose. I could go on forever. Please break me up.
This topic, improving healthcare access to minority populations, it keeps on coming up in every event I've hosted this year. And this is the reason why we're doing this event today. Why is that? Why are people constantly bringing it up? Why is this subject so important? Sorry, I didn't want to cut you off, by the way, Chris.
Oh, no, you're cutting me on, man. No. I love the back and forth. The reason why it's so important is because people are more and more aware that these are not God machines, that there's this phrase that people say, the data doesn't lie. And I'm like, my preferred phrase is, all models are wrong, but some are useful. And when I was with a team at a company called Actium Health back in 2019, 2020 timeframe, and we were really proud of the results from our predictive models to help identify people who had needs around CKD, cardiovascular, like we were identifying who needed communications about preventive measures that they could take. And we were proud of how well they were performing until this paper by Dr. Ziada Obermeyer comes out, and it highlights how a machine learning algorithm was biased towards bias in favor of white patients, identifying them for a high-risk program. Specifically, a Black patient would need 3 times the comorbidities to be just as likely to be referred into the high-risk program as the white patients. So we asked the hard question, didn't want to stick our heads in the sand on how our own algorithms were performing. And we found the same thing, that when we broke down by race and then the intersection of race and gender, we were underperforming. So that put a fork in the road. If we were to, you can interrogate the reasons why a machine learning algorithm that's based on hospital data would inevitably be biased if you're not addressing it. It's because the data that are coming in, that's reflective of the economics of the area. It's reflective of past redlining, or reflective of even people's cultural dispositions. Like by culture, some cultures are just have less of a disposition to go and seek services. So you're dealing with a biased data set at the onset. And the fork in the road was, if we continue with this ML algorithm, then what we would do, without addressing any issues, then we would be scaling up bias. We would be taking the bias that existed in the data, and the data is just a reflection of society. I don't like being stuck in thinking data is just on a spreadsheet. It's a reflection of when people were coming in for episodes of care to advance or save their lives. And by continuing on with the same algorithms unaddressed, then we would be scaling that bias up. By saying, all AI is bad, let's jump out of it, then we would just be allowing it to continue unabated. So our answer to that was to identify ways where the algorithm was underperforming and why, and identify standards that should be adhered to for each subclass, and partner with a third party. Partner with in this case, it was the University of Chicago. They have a Center for Applied AI, because we wanted a third party. We didn't want to just be giving ourselves a pat on the back. So the overall result was an increase in outreach to underserved Black and Asian patients, or even in some cases, in some markets, there were cases where white patients were underserved by the algorithm, underserved by our standards. So it introduced a whole new standard process that we implemented, and since then, there's been a whole lot of work and research on bias mitigation. And when we were asking this question, can AI improve minority access? It has to be done extremely well and extremely carefully. It has to be done with an understanding of causal mechanisms in mind, because the types of problems that led to the bias that Dr. Ziad Obermeyer outlined, and that we found in our own algorithms, in a lot of cases, like if there was better data science under the hood, better like machine learning fundamentals and causal data science fundamentals, then we would have had better performance overall anyway. And in that rising tide lifts all boats, better equity among our demographics. So equity is reflective of doing high quality work, is my kind of high level at that.
Can I ask you a question? And I remember I interviewed somebody about this time last year, and he said, as AI becomes more multimodal, I shouldn't say multimodal, but as you get more and more data sets, if there is a bias that is present in each one of those data sets, even if it's a very small bias, when you consolidate that, they can magnify themselves, those biases. Does that make sense to you from a machine learning perspective?
You know, I'd have to look like specifically at the use case, but one thing I want to impart is that you should always assume there is some kind of bias, and you should always be testing for it. So at the not knowing about the specific data sets that they're dealing with, we know that it's not going to be the same exact number of people represented across classes. And there's like class imbalance approaches that people can consider and take on. But even if we know that the inputs are similar, we still might get different outputs. Like there's so much nuance that happens when you're in what you're doing when you're combining and adding these data sets together is you're putting more and more dimensions or characteristics. Like if you think about rows on a spreadsheet, spreadsheet, for example, columns on a spreadsheet. If you're adding a bunch more columns on the spreadsheet, you're adding all kinds of opportunities for things and permutations and combinations to show up in ways that you might not have expected. So there's an importance in adopting an overall strategy to check for bias at every step of the way, especially when you're combining data sets.
Thank you, Chris. We're going to bring on Chris. You got us off to a great start. Sophie, you there?
Hi. Yes, I hope I am. Can you hear me?
Yes. Sorry about that,
Hooray.
Sophie. Well, let me get you. Let me get you. I got you. Boom. There you are.
Amazing. Hi.
Merry Christmas.
Merry Christmas.
And you've changed roles since the last time. So I think I haven't.
Yes.
Is it Adhera Health?
So it's not, well, it was Anira, and I'll tell you all about it and what we were doing. Sadly closed sort of later in the summer. So I'm, to your question, what hat is Chris wearing? I'm hatless at the moment. Although I do like the idea of a Christmas hat. I think it's, it's the season for those who celebrate. So yeah, I'm between hats, but I'm excited to talk about, kind of all of my experience across a few different dimensions of thinking about minority access and particularly the role that AI can play.
I'm so glad you're here, Sophie.
The pleasure is mine.
So here's the how question. We've had the why.
Mm-hmm.
How or what is the most foundational thing that organizations can do to ensure that health AI drives minority access?
Yeah, absolutely. I mean, there are lots of specific answers, and I'm sure we'll come into sort of specific use cases for AI, but I think the most foundational thing you can do is just have people with that awareness in the room and with the drive to, kind of make it happen. Frankly, you don't know what you don't know. No one knows what they don't know, right? So having someone in the room who can represent what you don't know is just absolutely crucial. So I'll give you a story. I was working at a health tech scale up, and I joined a project, and the project was using sensors placed on the body to capture data that would be fed into, health contexts. So, that's data that's going to be used for the care of individuals who are using the product. And I joined an all male team, and they were of a very similar demographic. And they said, well, this is what we've got so far, and this is where the sensor goes on the body. And I looked at my female body and said, guys, this isn't going to work for me. And that was immediately, you've got to have the right person in the room. And even then, we were all of a particular body type. We were broadly speaking the same ethnicity. So, kind of thinking about all of these different dimensions and how can we really diversify the workplace so that we're bringing people in who can say, well, what about me? Because it's, we need to get into the habit of kind of remembering, any one individual should be able to say, okay, well, I know that the diversity of the population that this product is being used for, but we're seeing that fail. So I think making sure that we're kind of giving real diversity to our workplaces is absolutely crucial. I mean, this example was from a fairly small company, but we saw in the UK during COVID, pulse oximeters, for example, a technology that had been used for many, many years, really, really widely used. But actually, if you had darker skin, if you had smaller fingers, if you had painted nails, it was hit or miss whether they worked for you. So if you're a Black woman who likes to get her nails done, you're really going to struggle to benefit from this technology. And again, it's thinking about when we validate these technologies, when we develop them, who are we developing them for? Who's in the room? There is a big bias in technology. Generally speaking, it's very male, very affluent, from a particular culture, very white. And so there are stories and books, to Chris's point, of technologies that have been built for that person because that person is the person building them. And there's still more that we need to do to bring in infrastructure in the way that we, develop these health technologies, that kind of, forces change in that area. So for example, the FDA currently does not mandate that every study on a clinical device is representative of the population where the device will be deployed. It doesn't mandate that you have reporting of sort of subgroups. We're kind of seeing baby steps. I think it was only 1992, I'm going to get my dates wrong, that you had to include a woman in your study, right? So there's a lot further that we need to go. The thing that interests me is that these examples that I mentioned, they're not necessarily AI-based technology. So why is it that AI is worse? To Chris's point, we're using data sets and there is massive bias within these data sets. And that reflects bias that we see in society. So in the UK, we have the UK Biobank. It's a data set that is, it's very valuable. It's very widely used. It's extremely wide. It's geographically very restricted. So we need to be aware of, what are we using this, kind of this data set for? Not to say that it has no value. That's not true at all. But we just need to be cognizant of the match between the data set and the bias in the data set and how it's being used and what we can do to fill that gap. There was a project that I worked on that was a cardiovascular risk score. We were thinking about all of the, different populations it would be used in, and even within that data set, and there was a good kind of distribution of different, ethnicities and genders and geographic spread within that data set. But we were looking at cardiovascular events and actually heart attacks. We discovered are underrepresented in Black men. So if you're a Black man, you go to the doctor and say, these are my symptoms, you are less likely to have it detected by your clinician that you've had a heart attack, and that's embedded in the data set. And so, there's this really big question of what can we do, mathematically or in terms of continuing to develop and add to these data sets to really kind of build that out. So for me, the bottom line, the most fundamental thing, bring people into the room who are, aware of and potentially have personal experience and really care about these issues so that they can drive them forward. There is a slightly separate question of should it be the responsibility of the minority groups to drive their own access to healthcare? I think that's a separate topic for a different day, potentially.
Thank you, Sophie. I have some more questions for you, but do you mind
Please.
if are you staying for the after party? Can you stay for the after party?
I might be able to stay for a bit. I'm recording a podcast after this, so I might have to nip off, but maybe I can come back in again afterwards, and I'd love to continue the conversation.
Okay, before you go, I'm going to call on you for your final word, and then you can come back.
Yeah,
It'll be
absolutely.
same
I would. No, I would love to. Final word now or final word in a bit?
before you go.
Before I go. Okay,
At the end.
fantastic.
And then, thank you so much. And next up, Val. Thank you so much, Val, for coming.
Good morning. Good morning. Grateful and blessed to be here. I'm excited.
And, I learned a lot about this from you when I first met you. And it's actually not often, because I think I was talking to you. I don't normally do this. When I met you the first time, maybe you think it's normal, but I don't normally. I said, oh, do you mind if I record this? This is really good. Boom. And there was something that really struck me when, oh, by the way, I'm not introducing you very well, Val. And Val's based in the United States, and you run a lot of events yourself.
Oh, yes.
I know you're running an
I'm
event
all
in
about
London.
people. Yes.
And I know you're running an event in 2026 in London.
Yes.
And can you introduce the audience? Introduce yourself to the audience.
Yes,
Do you
sir.
mind?
So, great to meet you, everyone. I am Dr. Val Torres. I'm the co-founder and chief operating officer of Health Board Advisors, which is an organization that helps startups to grow from seed to scale. I'm actually an operator, so I run the ecosystem and the company at large to better serve healthcare professionals. A lot of healthcare professionals complain that people are hearing them, but are they really listening? And I speak their language. I know their struggle. And being from a minority group myself, being Hispanic, Latino, whichever word floats your boat. I also understand the struggles of relating to people from other countries who speak other languages and other dialects and who have different cultural ways of doing things, so to speak. I hope that answered your question, Jose.
It does. Thank you. And something that really struck me is you said Latino communities and Hispanic communities don't trust health AI, and can you blame them? I remember that. Why are certain communities distrustful of health AI?
So that's the million-dollar question, right? So let's talk about who those communities are first, who don't trust AI. These communities, they're usually the marginalized minority communities. And just full disclosure, I'm talking through a lens of the United States. It may be different in other countries, but just empathize with me a little. So in the United States, minority groups, whether it's African Americans, Native Americans, Asian Americans, US Latinos, and Hispanics, they have all had issues in the past with things that affected trust. Whether for African Americans, the Tuskegee syphilis trials, whether Native Americans, things like Trail of Tears or Broken Treaties, with Asian Americans when it came to immigration or citizenship and their rights. And yes, a lot of these things have nothing to do with healthcare, but you know what? They affect trust. And everything revolves around trust. When you have breaches of trust and broken agreements, people aren't really going to work with you. And that generational trauma is really passed on. And these communities see certain institutions in a certain way, maybe negative, but that perception, it affects the way healthcare works, and by extension, AI. And the thing about it is, with AI is great. It brings a lot of solutions, but it also brings a lot of problems to the table that historically have never really existed. Things like privacy and health data, safety rights, job security, fair and ethical use of personal information. And these problems are relatively brand new. So, of course, these are the reasons why these communities are the lowest in adoption rates for AI and utilization rates. The takeaway message is it's all about trust. Yes, the past is the past. It is what it is. But now we know better. We need to do better. At the end of the day, people do business with people they like, know, and trust. And we got to focus on building that trust, Jose.
Thank you. Oh, by the way, I forgot to mention something
Yes.
at the beginning of the event. Miller, do you know about this? Santa Claus. SenzMate's doing a giveaway
Yes.
at the end of the event. There's going to be a little ceremony. If we're giving away SenzMate's giving away a prize, to be eligible, give a thumbs up in the chat, either on Zoom or on LinkedIn Live. We've got eyes everywhere. Give a thumbs up. Everybody who gives a thumbs up, their name goes into a virtual hat, and then we're going to spin a wheel. I've seen the wheel. Have you seen the wheel? Have you seen the wheel, Miller?
Okay, no, I'm also surprised. I'm excited.
There's a wheel. There's a wheel is going to come out, and the winner gets a prize. Sorry, I just wanted to get that up there. Thumbs up. We've got thumbs ups going, and so now I want to go back to Val. So you've outlined the problem. How do we as an industry, people who are innovating in health AI, and some of them are vendors, and some of them they aren't necessarily vendors, they might be in the healthcare org. The line is very blurry nowadays. How can we gain that trust? How can we earn it?
Oh, of course. It's not as easy as it seems. The short answer, by stepping up and doing the right thing. For instance, in my case, I'm working to coordinate an event in London next year in June, where we'll be launching something called the Healthcare Intelligence Board, which will be a doctor-led, doctor-operated board that will control and regulate AI in healthcare, so it can work for humans and not for corporations. And of course, we'll be working with ministers of health, countries to solve problems and to offer leadership and direction. Anybody is welcome to reach out to me to work with me on this, but Jose, it's all about building trust. And there's 5 things that I'm going to be working with in building that trust. So 1, transparency. We need to clearly communicate how AI works and how it uses data and the strengths and weaknesses. 2, education and awareness. We need to teach people about AI and how it works for them, how it benefits them. And we need to be honest and explain how the health data is being used and how they can protect themselves and safely use AI. 3, career support. We need to help people upskill and reskill their opportunities in life to future-proof their careers because AI is coming. We can't stop it. We just need to adapt and move forward. 4, accountability and compliance. We need to make sure that healthcare professionals do the right thing. We need to obey the law. We need to obey ethics. We need to have professional standards. And of course, we need to do the right thing always. So we need to avoid breaking trust and exploiting communities, whether it is intentional or unintentional. And the last one, 5, we need responsible AI use and policy advocacy. So ethical AI deployment in healthcare, it needs to be promoted. We need to shout it loud from the mountaintops. We also need to advocate for policies that benefit everybody in society, not just the top 1% of the top 1%. And when we say benefit, say AI is going to be replacing current jobs. We need things like universal basic income. We need equitable access to technology. So yes, AI may be replacing jobs, but in the long run, it is also creating jobs. So there's more of a benefit than a loss. So overall, Jose, we need to stop throwing money at the problem. What we need to do is roll our sleeves up, work together with the patients, and really get the work done and build that trust. It's all about working together, right? This AI issue is going to be something that affects all of us, regardless of whatever country we live in.
I've got one more minute. Val, I got one more question I want to ask you.
Yes, go for
We
it.
have a short answer. And what does it enable? We've gained their, let's say, we've earned their trust. If we've earned their trust, what door does that open up?
So, Jose, let's talk about dollars and cents, because that's the language that everyone speaks. So, in the context of the US Hispanic and Latino community, unlocking that trust unlocks a $4.1 trillion market in terms of spending power and GDP, right? The US Hispanic community is growing rapidly. And guess what? The bigger the population, the more AI is going to be used, right? Also, when it comes to STEM and workforce participation, more US Hispanics are getting into higher education, into STEM, right? STEM is going to be using a lot of AI. And of course, people need to supply these professionals with AI. Money's going to be made, of course, but if there's no trust, Jose, nobody is going to use that AI. It's going to affect all of us. And lastly, the economic impact. Of course, by gaining trust in this community, you have your products and services in AI being used, and you unlock the 5th largest global economy in the world. That is the US Hispanic and Latino community, right? You will have more AI in healthcare being used by everybody. And guess what? People are going to live longer, healthier lives. It should benefit all of us, but trust. Trust is something we need to unlock.
Thank you, Val.
You're welcome.
Thank you so much for that. And we're bringing Val back for the after party. Alex.
What an inspiring conversation. Thank you for inviting me. I'm very, very happy to join today.
Thank you. And Alex is a health economist. She works for the NHS. And I was actually, Alex, you're probably tired of hearing me say this. I was like, oh, what's a health economist doing in health AI? I thought you all did pharma market access. And which is probably dumb of me to think, but that's what I thought. I guess that's my experience. And you also curate a community for Latinas in the UK that are working in healthcare. You're based in Manchester. And have I done a good job of introducing you?
You have? Yes, absolutely.
And
wear another hat. Until recently, I am a charity trustee working with Latin Americans who migrate to London.
So I'm going to ask you one question, and then Miller, I wonder if you can jump in and follow up with her when she's answered
Sure.
this question. And where AI has failed to serve minority population. So where has AI failed in healthcare in terms of serving minority populations? And what are the consequences of that?
Thank you. I would like to start on a positive note. So I'm going to come back to the title of this conversation. Can an AI improve minority access? My stand is yes. We have failed, but we can do better. So coming back to Val's points, we should and must do better. That's my starting position. So AI can improve access for minority communities, but only if we intentionally design and implement with equity at the core. So there's a lot to do. We can't just say we have failed. Let me start with this. So if we ignore this equity standpoint, AI risks replicating and amplifying existing inequalities, like others have said before me. Events like these are necessary. We have to be doing it consciously and getting more and more awareness and attraction to these sort of topics. So I want to respond to your question, bringing 5 key reflections, Jose, if you allow me, and the audience as well.
Oh, yes, please.
There is a big structural risk around digital exclusion. So we are not only talking about data bias, which others have talked about, but also we're talking about other factors related to the design and implementation. So there's a lot about implementation as well. I am referring about skills and confidence. Val touched a little bit on this. I am referring about creating supportive environments with affordable and reliable internet connectivity and devices. So talking about some basics as well. I am talking about creating culturally and linguistically sensitive AI technology. There's a lot around language as well. And I am also touching on awareness about trust. Val talked about this, and offering a psychologically safety space for people to talk. So again, coming back to basics a little bit, we're talking about change process. So there's talk, collaboration, and team dynamics. Without tackling all these, overall digital health, AI or not, risks widening healthcare inequalities. So let's have that in mind. So in a previous conversation with you, Jose, we touched about trust as well, and how sometimes this is treated as something that is too abstract to be measured. I am an economist by profession, and I have been reflecting a lot about how do we incorporate this that is so hugely important when people are testing new technologies, new system, and embarking in new things when there's a lot of pressure and uncertainty. So that's one to look at. My second reflection is about there is a lot of evidence, solid, robust evidence that is published already, argumenting and bringing data around how AI is failing to serve minority groups. So there has been some reflection done by Natasha earlier around cardiovascular diseases. There's some evidence as well around imaging. There is less evidence around other pathways, but that doesn't reflect that there is no effect in these areas. It's just simply we don't know. It hasn't been measured. It hasn't been shown. So there is a big lack of disaggregated outcome data that in itself is a structural neglect. So let's keep talking more about that. I'm going to give you some examples, but there is just a recent systematic review of cardiovascular AI models published earlier this year in February, showed that 9 of 11 studies found racial and ethnic bias in performance. There is also some evidence published by Cornell University in a study around demographic bias of vision language foundation models in medical imaging. They found that medical imaging AI reproduces bias under diagnosing Black, female, and also intersectional patients compared to normal care given by radiologists. So there is a lot of evidence that we can be talking about, and it's important to consider how results, how things are given, and how there is this status quo in how things are being analyzed and published and shared. My third reflection is around disaggregated data and analysis. We need to get more serious about equity disaggregated analysis in all healthcare systems. In the UK and globally, there are lots of promising pilots around many types of technologies, for example, ambient scribe tools, national labs, and different platforms. They often report aggregated gains, and they lack disaggregation and breakdowns by ethnicity, language, and socioeconomic profile. So language is a big thing. I'm just going to say this because this is in the top of my heart. I speak Spanish, and I feel that people needs to be more aware there are plenty of languages. And the reason that I am speaking in English is because most of the people we speak English, but there's a reality, there are plenty of different realities and languages. So we need to rethink as well, who are the users of AI technology? This involves patients and staff members as well. Systems in different countries employ diversity healthcare population, and they serve diverse populations as well. So these are the type of users. There are different layers we need to think of. Without equity disaggregated analysis, we cannot assume equitable benefits, equitable changes in productivity or health outcomes. This is not realistic, and we need to move on from traditional ways of doing things. We are in a time in which we are being challenged by thinking and doing things differently. My fourth reflection: before technical and research fixes or changes that include better data and updated evaluation methods, we need to rethink partnership working that is reshaping at the same time policy and governance. So there should be mandatory disaggregation of outcomes. There are a lot of things as well that we have to celebrate. People are working very hard to move on. And I'm just going to give one example. There is this collaboration that it's called the Initiative Standing Together. And this is a brilliant example of building standards for data diversity, inclusivity, and how to generalize data and outcomes. So as part of the NHS AI Labs Ethics Initiative, this is a partnership between 30 academic, regulatory, policy, industry, and also charitable organizations worldwide. So we can see that people is starting to, partner and working together for the sake of this, and we also need to celebrate it. So we need to shift, and we need to celebrate the progresses and small wins that we're having. This collaboration has resulted in a set of recommendations in a set of international consensus process, which is fabulous. And this provides guidance on transparency. This provides guidance about who is represented in the data, how people are represented, and how data is used when developing AI technologies. So that's brilliant. Right, I will finish with a final reflection. As we fail to pay close attention to how AI affects minority access, the consequences will be profound. We need to keep working on this, and we need to keep insisting around how we can move on. When health AI systems systematically underserves minority populations, we risk widening the existing gaps that are already concerning. There are gaps in diagnosis, gaps in treatment, morbidity, and mortality. And over time, this worsens, just creates bad health outcomes, but also, like Val said, this is going to keep eroding confidence in our health systems. Undermining processes these technologies are meant to support. So we need to look at this. Ultimately, inequitable AI doesn't just fail patients or healthcare staff members. It fractures trust, and trust is the foundation of safe and effective care. And as the saying goes, and I will finish with this, in healthcare, change moves at the speed of trust. Thank you.
Thank you, Alex. Miller, I said you're going to get a chance to answer a question, but we've actually.
Yeah.
We have to move on. But you're
Sure,
going to get a chance,
we'll
Miller.
keep it for the outer half, yeah.
Dr. Cat, are you there? You're going to get a chance right now, Miller, but with someone else. Dr. Cat, are you there?
Yes, I am here. Yes.
Yay. And, oh, where'd you go? There you are. I'm going to make you big. I don't know how to introduce you, Dr. Cat. And you do so many different things. And I think you have more degrees than I have, that I own pairs of shoes. And I know you're based in Spain too. And you speak a lot of events. I'm wondering if you can introduce yourself quite quickly.
Yes, certainly. So I believe that maybe to bridge with what you just have mentioned, one of the very interesting things is that we all have biases, all different kinds of, and we like to basically, like put people in the boxes. I believe that one of the biggest challenges which I bring in other people's lives is to unbox me. So if they would like to say, oh, that I am, let's say, coming from Poland and I would be identified in this way, then there is a bigger picture to it. You used to live in a couple of different countries, including Asia. And so I believe that the perspective here is what is really needed is the big picture. And one of the topics which are connected to my life purpose is to have, let's say, bringing all different kind of means of innovation into healthcare, but also taking different aspects to it. So my background is coming from engineering, PhD in physics, but also, with biological aspects. But also in order to bring the innovation forward, we need to think about how to protect it. So there is a patent side to it as well. Or, how to bring the technology transfer. And moving forward, how to market this, how to make products which will be actually helping and saving people's lives. And then moving forward, how actually speak more about that and how to bring new innovative tools inside of these products. And so that's how artificial intelligence is panning out. And in all that, eventually, what is the most important and critical thing is that all this technology means nothing at all if we actually do not put people in the center of it. So eventually, what is really the center of my attention and interest is really people. So that's a little bit about me. And for this, I love to wear many hats. I love to speak different languages. And I can definitely mention, a few things about that topics about, like speaking about how can health AI improve minority access? Because I have been actually, let's say, faced with the fact that I am a minority very often. Like I am a minority now, staying in Spain, even though I love to, learn the language. But if I try to use all different kind of tools, very often AI is not able to follow up with me because I write in 7 languages. So it is a little bit sometimes challenging. But if you would allow me, I would bring a little bit of the idea, of why people actually, so again, like bridging with what Chris had mentioned. So why we speak about the minority access, why we actually, started to talk about this issue. The thing which is happening, so I have data from different countries and a little bit different, kind of ideas of how is it. When we take a look at, Americans, so just let's put a little bit United States in the spotlight, only 39% of Americans view AI as more beneficial than harmful. And 58% are believing that the regulation won't go far enough to actually protect them. So there is a really huge trust deficit. And for this, 39% of AI experts at private company feel that they have little to no confidence that US companies will develop AI responsibly. Now, it changes from one, I wanted to have a, let's say, global overview on this topic. So it's a little bit more positive, interestingly, in Asia, where people are a little bit more seeing AI in a positive way. So, for example, AI Singapore, a sea lion model, increased, the representation to 40%. So there's really a lot of countries which are working very, tirelessly to make the improvements. I wanted to mention also, I was mentioning this a little bit. There's a lot of, let's say, restrictions coming from Europe when it comes to many things. And sometimes it is, pointed out as limitation to the development of, technologies, of innovation. But in Europe, we have the legislative framework of EU AI Act, which was really presented by amazing people, because I have had an opportunity to get to know a couple of those people in person, and they bring a couple of very important topics in advance. So first of all, there are some prohibited practices where it is actually brought to the attention to outright ban on biometric categorization in the system for the inter-race, political opinions, religious beliefs, sex life, or sexual orientation from biometric data. And there is also a ban on untargeted scrapping on facial images from internet or CCTV footage, which there are some countries around the world are already using those kind of, let's say, technologies, right? And there is one thing to implement it. Unfortunately, there is a high risk for people who are not going to, follow through. So this is going to be implemented over the next, couple of years. High-risk system requirements are effective on 2nd of August 2026 for any companies which are willing to work in artificial intelligence and come to Europe. They need to be very mindful of that. So there is a mandatory examination and assessment of possible bias in training, validation, and testing data sets. This is the Article 10. Systems must undergo conformity assessment before market entry. And I might tell you that as expert advisor and evaluator on different multiple European projects, whenever artificial intelligence was involved, we also as expert were evaluating if the artificial intelligence were done, or let's say provided in an ethical way. Now, there's never a real enforcement without, a real implementation without enforcement. And so for the enforcement, that's not that fun part. It's a little bit like we have big fines in GDPR in Europe. So fines can go up to 35 million euros or 7% of worldwide annual turnover for prohibited AI practices, and 15 million or 3% for high-risk system breaches. So it will have to be implemented, and I believe that maybe that's the reason from one side that Europeans have a little bit more of trust into AI, but and there's also some kind of programs like Mammoth project, which I am very aware of, which brought a little bit of the study, but there are still disparities, and so those disparities are very often used in all different, let's say, or encounter in different applications. Many of them come to mental health, which I am very fond of. That's the topic which is, I believe, very important. And maybe to bring a little bit different angle. So already why this trust, comes into especially artificial intelligence and mental health. Because it is not really done totally within all the inclusion criteria as they should be. It's a little bit like Chris was mentioning. It's not something which, I believe is taking in account at the very early stage of founders starting to work on any innovative idea. It turns out that the models, use usually data which is pretty biased already. And what happens very often in mathematics, and so excuse me for getting to the geek out a little bit to the side, but very often if you have multiple issues, it's not that you add them, you actually multiply them. So if it's 10% of issues here with artificial intelligence and bias in here, then 10% in here and 10% in here, then it starts to be a very big number when, we just bring all these little issues together. So I believe it's very important to keep people aware that, things like this happen. And what is really also very kind of interesting is that there is also use of many companies like trying to, skyrocket or just go faster, to not to use any rules whatsoever. And what happened is that very often they would make their applications free for the users. So the users are completely unaware that their data is, basically stolen in many cases, I must say, that it's used very often inappropriately, that actually it's used to create really, like fantastic ads for them and to make them buy and buy more and, get more and more hooked and connected to, all these different social media. And what is very difficult with all that is that we also have to speak about this proportion when it comes to young people and children. So when we speak about, like any kind of minorities or discriminations, there is also this topic as well. So I believe it's very important to bring more of awareness. I am actually voicing, when it comes to this topic a lot, especially lately, because we see more and more different kind of applications, more and more, kind of really very dangerous cases coming on. To give you an example, so for example, character AI, personal AI were having some issues. It was also in Europe because they were bringing very explicit language with sexual harassment even towards underage and minor, really, like basically kids. And so when things like this happen, that's the general public which will have also a very negative, idea about all these different kind of applications. However, there's also a lot of positive things. So I need to say that there's a lot of companies who go through this struggle of clinical validation. So there were a couple of them. I actually had an opportunity to co-organize a conference last week, which was really focused on mental health and artificial intelligence with a couple of amazing speakers. But also I do update of all different newest, kind of technologies and tools, frankly speaking, for adults, but also for kids when it comes to their mental health. And I must say that there is really a rise of amazing companies. I really loved, for example, Kai, which is a little bit like speaking on WhatsApp with your best friend, but it's with clinical studies. There are a couple of other ones like that. So, whenever we take a look at this topic, I would like to not be only negative all the time. It is very hard work. Imagine companies have to go through crazy struggle to get this AI Act correctly. It's going to be very difficult.
Dr. Kat, do you mind if I stop you there?
Of course.
Because we have to spin the wheel.
Yeah.
Before the LinkedIn Live closes.
Yes. Sure.
And do you mind, I didn't want to cut you off, but do you mind we go back to that during the after party?
Yes, of course, yes.
And we still have one speaker who hasn't spoken yet. And I'm wondering, are we ready to spin the wheel? Miller, you're going to get a chance to speak. So we have 6 speakers to this event.
Yeah, that's right. So let's go with the final speaker. I think that we'll go.
We have to spin the wheel, Miller, before the LinkedIn Live closes. Is the wheel here?
Yes, with Rehma, Aiden. Are you ready with the spin the wheel?
Here we go.
Yes, I think yeah.
The wheel is coming. There's everyone's names who put their thumbs up.
Yes, it had it in.
And thanks for coming, David. We're spinning the wheel. Oh, we've never done this before in a webinar. I feel like a game show host. And Annie Rosita wins a prize. Annie, you're going to be contacted. Santa Claus is paying you a visit. Oh, is it spinning again? Oh, there's 2. We're spinning it twice. Dr. Ritita Shahu. I probably pronounced your name wrong. I'm really sorry about that. Oh, the wheel's spinning again.
We can choose 3 of them. So that's where we.
Okay.
Go.
Santa Claus, Christian, Paul Singh.
Right.
Okay, Santa Claus is paying you
We
a
have three
visit.
people. Thank you,
Okay,
Rahima. You can close
thank
now.
you so much.